Thank you all for your patience. I think par for the rest of the hackathon, we're running a little late. I apologize. Like I said, we just had some major technical difficulties getting these slides put together. But they're together now. We're very excited about that. And I just wanted to say that I have enjoyed getting to know all of you in this track over the last 48-ish hours. And yeah, and hearing all of your ideas has been really, really great. So yes, thanks again for all your patience. And can everyone see my screen well? Just to confirm, I'm just...
Yes.
Okay.
Yes, we can.
Yep.
Very good.
Okay. I'm trying to... So, great. So the hackathon process, as you guys saw, we had our problem pitches that were all virtual on Friday night. And then from there, we kind of let you guys take it amongst yourselves, and you got to kind of virtually meet everyone and form teams pretty organically. And I hope you guys all liked that process. And once you guys kind of knew what you were looking for, you were able to then hack and get feedback from all of our wonderful mentors who've been super flexible, and I hope you've enjoyed working with them. And then we got to go over what we were doing through all of our practice pitches, and then we were presenting our, we were at the presentation part now, finally, thank goodness, right? So the judging criteria, we'll go over that. So this was in your participant guide that we sent out when you first joined our Slack. The impact, does the solution solve a real problem? The innovation, does the team provide a convincing rationale for why their solution would work, and do they address significant technical issues relevant to their problem? Implementation, could the proof of concept, prototype, or preliminary vision be executed upon? I'm not going to read them all word for word, but just a few. Presentation, how effective was the presentation? Does this team have what it takes to carry on the project and move forward? So those are some of the things that the judges are going to be judging as they're listening to all of your wonderful talks. And someone else, okay. Our track F judges, one Suzanne Shirley. I do have an intro for her. Suzanne Shirley is the Director of Partnerships and Community Engagement at BHA Innovation Ecosystem. Rowan Cade is the consultant at BARDA Drive, that's the Division of Research, Innovation, and Ventures. And Ethan Gershon is the InterSystems Physician Executive. So these will be your judges today. We're very glad they could help us out. Okay, so as you know, this has kind of been, these are all of our sponsors. A lot of these sponsors provide a lot of mentors. So a lot of your mentors are probably from some of these places. We're very thankful for all that they've done, and we really appreciate their support. Okay, without further ado, team sharing is caring. I'm going to see if I can't, are your hands raised?
Hello, Hannah. We are the Corona Survivors Mission team. Can I request a remote control so that I can move my slide?
Yep, I just approved you.
Perfect, thank you.
Oh no. I'm gonna have to open system preferences, hold on. Oh, I can't do that, unfortunately. That is not gonna work. Well, actually, maybe it can, let's see.
No, I can move your slides now, I think.
Can you really?
Or
no?
Give me a second. No, I don't think I can.
Okay. Oh, it just moved. Someone moved it.
Let me see.
Was that one of you?
I can move them, I think.
Okay, if you can move them and you want to go ahead, I will have a timer and we'll start your 3 minutes.
Perfect. Okay, so hello everyone. We're gonna present Corona Survivors missions. Okay, no, it's not moving. So if you can
okay, I'll move it.
Okay. So what are the problems? We have a 43% of the global population that is confined. The economy is crashing. There's no vaccine, no test, a fear from the population, a complete saturation of the healthcare system. And by flattening the curve, we're actually prolonging all the dramatic situation. So what do we propose as a solution? Next slide. We propose to empower the Coronita soldiers. So who are them? They are the people that have tested positive for the virus, but that have recovered. And we are talking about 250,000 people worldwide. And this number is increasing every day, but about 20K more people per day. So we want to create a pool and we want to create a non-profit organization. Next slide. So how to do this? We want to focus on all this population that is infected. In the US, 1 out of 4 infected people are going to end up in the hospital. And for those people that tested positive for the virus, and 88% is going to recover. And those recovered can get a medical certificate, official certificate. And we're talking about 4K people per day in the US recovering, and they can join our patient pool. Next slide. So once they join the pool, they're joining what we called our solution, the Pangolin platform. So this platform allows you to physically go back to work. You can donate plasma or blood. You can also join volunteering opportunities or other jobs. And you can also give your data for us to profile. Next slide. And also create an algorithm to go back to all those people that maybe had mild symptoms and did not end up in the hospital. So that we can test them and get their certificate as well if they tested positive and recovered, and put them into our platform as well. Next slide. So we want to partner with all of these institutions to create our platform, but then our main worry to start with this solution was how can we reach to all these people that tested positive and recovered from the virus. Next slide. So we thought that a good idea was to create a social media campaign. Next slide. And we got inspiration from some very successful campaigns from World War. And we put a little bit of fun, a little bit of irony to try to decrease this fear from the people. Next slide. And we also thought, next slide, why can't we include celebrities such as Tom Hanks, who actually had the virus and recovered from it and could join our platform to also reach to these influencers or celebrities. Next slide. So what's next? So starting from tomorrow, we can start prototyping our platform, contacting the partners, testing it, reaching the KOLs, and launching the campaign. In the long term, we want to shorten the curve, relaunch the economy, and learn the protective rate of natural immunity against this virus. Next slide. So this is our amazing team. I have them here with me right now. We are actually roommates, so we have a lot of diversity of backgrounds, but also national.
You're at 3 minutes.
And yes, we had a lot of fun this week. And next slide.
Okay, we are at 3 minutes.
Yeah, this is the end, the last slide.
Okay, perfect.
If you survived COVID-19, please join and COVID-20 crew. Thank you very much.
Awesome. Great, thank you guys. Judges, we'll have 2 minutes for some question and answer.
Hi, this is Suzanne Shirley from the VA. I'm wondering how your solution could be applied to managing the healthcare workforce with a large integrated healthcare system like ours.
So I think from these people that will join the platform, they can definitely help the healthcare system, as they would be the most likely to be immune. And we think that the ones that are doctors can, of course, be in the front line with the most vulnerable ones and the ones that are in most risk. But also, even if they are not doctors and there's anything they can do to help, we have this option from the government, from institutions, from other companies that they can post their jobs and the things that are most in need at the moment, so that they can volunteer and maybe even get trained and help with that, the most in need.
Thank you. Great job.
Thank you.
Hey, this is Rowan with BARDA HHS. So what criteria will go into a certificate of good health or a certificate of immunity upon discharge? Have you guys thought about what type of criteria a patient will need to meet to be able to be certified?
So I guess for us, it's mainly that they got tested positive from the virus and they have no more symptoms. And as soon as they get out of the hospital, the doctor would sign the certificate confirming that this person is healthy again. I don't know if you want to add anything.
Yeah, may I add? This is a solution like waiting for serological tests to be developed. And then serological tests will be one more tool to get to these people a certificate of immunity. And for other people that we would screen through the algorithm, we would, of course, select people with no comorbidities factors, such as diabetes, such as disease from respiratory or lungs, or like certain range of ages.
But we need to make sure that it's agreed within the healthcare professionals about what to put in the certificate and what are the terms and how they can accept people to join.
Gotcha. Thank you.
Great. Thank you guys so much. So next, going to be having Team Cobus.
So we have multiple presenters. Just want to make sure that that's okay.
Yeah, and I will have to turn the slides due to the security on my computer since it's a work laptop, but go ahead and you guys can unmute yourselves. Are you guys
Am I muted? Can you hear me?
Nope. So, okay, I will start your timer and you guys will have 3 minutes, okay?
All right, great. So this is CODIS. Our solution, even we can go to slide 2. Our solution is looking at the problem.
Hang on.
Oh,
that's
Slide
not
deck
our
is
slide.
not-
no, it's not.
Are they not in order?
This is not us. Thanks, John.
Excuse me, this is last
That says test for immune over there.
Okay, someone didn't do these right. Okay. Test for immune. Are you guys good with going now?
Can we get a little bit of time? Like we just got to know right now.
I can't hear you guys.
I think they're asking for a little bit more time. It sounds very faint though.
Hey, Hannah, you got Henry here.
Hi, Henry. Henry is joining us now. He's going to be helping me run time. That way I don't have to run time on things. So hi, Henry. He's part of our team. Okay, let's see.
So we're going to do 3 minutes for the presentation. We'll keep a cutoff there, and then we'll have 2 minutes for judge Q&A.
Yeah, the problem, Henry, is that the slides are not in the order that we thought they were. So
Slides are not in the order they're not, the order of the teams doesn't reflect what you have on the paper, or slides all just got jumbled out of order entirely at random.
The cue sheet for them are messed up.
And we just do it, roll with the order in the deck. The order was generated randomly anyway. Everyone's expected to be on for all presentations.
Yep, so we're basically just gonna do them as they come. I will try to put, Henry, can you access the deck and maybe you could put in the chat what is the next one? I can send you the deck on Slack.
Slack me the deck. I'll put who's on deck, and then the way we were doing it over on E was we were allowing one member of that team to take control of the screen at that time.
Yes, I can't do that. So my personal laptop has crashed and I'm on my work laptop, which I cannot let applications take control of it due to security concerns. So I'm just going to have to switch for them.
Yep. We'll just have a very clear thing. Yeah, next slide, and then we'll go.
Okay. Yep. Okay. So starting now, test for immune, you guys are up. Go ahead and unmute yourself, and we'll try to be sure that we're putting who's on deck. Henry will take care of that. Thanks, guys. Test for immune, we can't hear you.
Yeah, our audio is bad right now. We're currently troubleshooting.
Okay. Well, I think we'll move on to the next piece.
Yeah, we can present after the team.
Actually, do you have anyone that's, so whoever is talking, we got to have someone present.
Okay, yeah, I could present.
I think it'll be a lot of time to go back and forth, and if they end up getting feed, then they can take over, but we should
Okay.
go ahead.
Should I begin now?
Yep.
Hi, so we're Test for Immune, and we essentially developed a kit for high throughput testing immunity. Next slide. And here's our team members that worked on this project. Can we go to the next slide? And so here we need to understand the problem. There's heavy dependence on RT-PCR for diagnosis, and that test is very costly, which isn't suitable for low-income environments. And currently there's an absence of high sensitivity screening techniques for immunity, and there's an absence of databases for immune populations. Can we skip over to 2 slides? And so our solution is we developed a formula for diagnosing patients, and it's an automated dilution lateral flow assay. It's rapid, it's low cost, and no lab expertise is required to detect IgG/IgM antibodies against SARS-CoV-2. And here we're introducing a sensitive yet affordable screening test. And in future directions, we hope to maintain a database of service providers that are immune to this virus. And hopefully this will cut down the costs and improve the front line for healthcare workers. Can we go to the next slide? So the current testing methods is an enzyme-linked immunoabsorbent assay, or an ELISA, or a fluorescence activated cell sorting, FACS. Can we skip 2 slides? These methods are expensive, so we decided to stick with the lateral flow assay design concept. So the method is used in many pregnancy tests and involves capillary flow, bringing a sample across the membrane, conjugating with antigens, and then presenting themselves at a capture line. And this does not require any fancy lab equipment and can be used by any individual. And the test strips are really cheap, ranging from 50 cents to $1 to manufacture. And as you can see, there's a designed concept on the top right, or bottom right. Next slide. So this is our lateral flow assay molecular design. So the sample is the blood, which will contain IgG and IgM, and then the conjugate labeling site, which will conjugate these antibodies. And then the test line 1 and test line 2 will test for IgG and IgM respectively, and the control line will determine if the test worked. Next slide. And so here's our design. So we begin at the sample well. We conjugate the antibodies, and as it goes through the strip, it's going to constantly get diluted. The solution will constantly diverge off, and at each point, we can see that bands can be generated at 4 locations. Next slide. And this is the graph showing IgG and IgM levels during different phases of the patient's
Guys, that's time.
Okay.
So we're gonna stop there, and with your 2-minute Q&A, judges, feel free to take it off.
Hey, this is Rowan from HHS. What is unique about you guys' lateral flow design compared to any other? Is there unique about what your design does and what advantages does it provide?
If I may tune in,
Previous slide.
Wait, can you hear me?
Yeah, I can hear you.
Okay. If I may tune in, what's unique about our lateral flow design is that we have multiple dilutions going down, and we can actually compare the relative concentration of the antibodies to each other. So the IgG and IgM. So as we compare them, we can place the patients along this day since infection curve based on how much IgG and IgM is in their body.
Gotcha. So you guys can basically create a quantitative result or semi-quantitative result.
It's more of a qualitative result, but you can actually compare them relative to each other.
Yeah, so basically the patient would count the number of bands, and based on the number of bands, they can tell how much IgG and IgM antibodies there are relative to each other. They can determine the relative amount inside their body.
Thanks.
Hi, this is Ethan Gershon. Are there other examples of this dilution method on the market, or is this dilution method on the paper an innovation that you'd have to bring to market?
We haven't seen any dilution method in any papers or on the market.
Interesting. Thank you.
Have you utilized this method or the multi-dilution method for other infections or other diseases?
I know that the lateral flow assay is used to diagnose things like HIV.
Yeah, no, I mean, lateral flow is very common across. I'm talking about this specific multi-dilution within lateral flow.
We haven't considered that yet, since we only had one day to design.
No, that's fine. I was just trying to understand background and see other things. So.
Theoretically, you could do this on. Theoretically, you could do this on any other virus.
Yeah. No. Yeah. Got it. Understood.
This is Susie from the VA. Do you have plans to partner with manufacturers to bring this to market, or?
We currently don't have the plans to bring. We haven't connected with any manufacturer yet, but we hope that through this experience we can possibly connect with the manufacturer to hopefully bring this product to life.
Okay.
All right. Thank you, guys. We're at time for questions. So let's have that come down, and we're going to kind of live fix this, I think. So Hannah, are you able to stop screen sharing? I think I can take over screen share and then triage the request to give control selectively.
Right. Okay. So I will stop my screen share.
Let me see if I can do this.
Yours.
Bear with me, everyone. We appreciate you being on the line.
Yes.
All right. So screen share. You guys seeing my screen?
Great. Yep.
Great. All right. So team sharing is caring, Corona Survivors Mission. So here's what we're going to do. So
we've done them.
We've done them already. Great.
And then we see, so.
Team Covis.
And that is actually us this time.
Yeah.
Great.
So I have no idea why the slides are. Okay.
Got it. So here's what we're going to do. So everyone can also see who's on deck, correct? Like who's next to present?
Yeah, and I can go through.
So coming up, CODI, right? You're going to take silence as as yes, you can see that.
Yes.
So what I'd like is that, cool.
Yes, we can see from Quaranteam. Thank you.
Awesome. So I should, how can I give you control?
I think we are actually
we are good
okay. Yeah, we're okay if you guys have control. Just a heads up.
Okay, I'll click through for this one. We'll deal case by case. So let's go. Just say
Thank you
yes.
very
You
much.
can say next, and I'll know that means go, and I'll also be timing. So here we go.
All right, cool. So we're Covis. We can jump right up into slide 2. So next slide here. So we're looking to solve the issue of identifying the COVID immune, which is to say identify those who have already had and recovered from COVID but never had an official diagnosis. So current estimates would be that there are almost 8 million patients who fit into that bucket or will soon as they recover, and that number is going to continue to grow. And the current antibody tests are just not prepared to scale to that demand. So on the next slide here, where we see the benefit here is to individuals, certainly, where with informed information, they can potentially make informed choices about quarantining. Health systems are already overburdened, so anything we can take out of that antibody testing stream and find a technology solution to, that's great. Governments obviously could use insight into immunity status in order to drive their public policy. And of course, payers always want to reduce unnecessary tests. So on the next slide, what we have proposed for a solution is our platform Immunity. Immunity is going to ingest user-submitted data on background information, historical symptom information, as well as device-generated location history data, combine those data with big data sets, run through a predictive algorithm, and then generate a personalized likelihood of immunity score to present to users. That will allow them to make informed choices about how they start to choose to re-engage with their world balancing their individual needs and situations. On the next slide, we'll walk you very quickly through the user experience here. So we're essentially asking about any confirmed diagnosis of COVID, some additional factors that might indicate that you did in fact have COVID, including symptom history. We're uploading that location data so we can do location cross-mapping, and then we're generating this immunity prediction. And on the next slide, John's going to take us through how we get there.
Thank you, Jeff. So how does this work? The immunity forecast that the user is given is derived from location history, big data, and personal information. We then weigh this against a variety of factors that we have built into our algorithms, some of which here are shown here on the slides. This in turn gives the user a personalized dashboard displaying key factors, a score, and what this might mean for them in their daily lives as they navigate the current situation. On the next slide, we put together a quick look at other products in this space. And as you can see here, many of these did not use device-recorded historical location data or attempts to fuse multiple data sources to derive stronger inferences about their users. And in the one case that we did find this, the solution itself was just not scalable worldwide. On the next slide, you can see some of the feedback that we got using a survey we sent out. And the majority of our potential users indicated that they were either comfortable or very comfortable with the concept and appreciated what this could bring to their daily lives. On the next slide, you can see our launch strategy. And we start here, of course, with the design and build phase, in which we're getting data and input from academia using grant and seed funding to fund us. We're then moving to the validation of our solution using an MVP launch on 2 small or mid-sized cities, again, continuing the grant and seed funding, and then moving to the rapid launch and, of course, the large scale overall. Our next slide showcases the awesome dream team that we were able to put together here. And we want to say a special thank you to everyone for this opportunity, in particular our mentors, Nime, Jin, Gerald, and Steven, as well as the organizers, Hannah, Alfonso, and Freddie.
All right, thank you guys. Just at time.
Thank you.
I feel, and there we go. So let's we'll pass it over to the judges now for feedback.
Hi, this is Ethan. Is there any literature base you're drawing from that talks about prediction of who's likely immune? Or is this, well, I'll leave it at that.
So I'll take the answer. This is Ian. We are drawing from common knowledge because there's the literature for COVID is just about coming up. This will be primarily a data-driven technology. So we will draw from the public data that is being published and also the knowledge which is coming out of current literature. So yes, we will do a literature survey. We will draw on current data and all the evolving data that we know will come out in the next few months because this is a major region of study now.
The one analog I'd add to that too is I think what we're essentially trying to do is what's commonly practiced as contact tracing, and we're attempting to automate that through that overlaying location data, proximity data, essentially.
Thank you. If I may ask a follow-up question, are you aware of—
How do you guys plan to get user adoption?
Sure. So I think this is going to be quite different in the different parts of the timeline. So during the MVP launch, this is going to be through our partners. That will probably be like governments or healthcare providers in a small scale. And then once we get to the rapid launch scale, state, that will be through kind of large scale partnerships with care providers and governments, and also doing some grassroots organization campaigns. And then the final part, which is a scale and localized part, we will actually have an SDK package where we will utilize local communities of different markets where they will know the networks and the data available better. And then that way we will have an online community support on how to launch it based on the previous stages experiences, but then also leverage different partners' networks in that way to scale really quickly.
All right, guys, thank you so much. All right. And here we go. Next up is Team CODI, and the UMD Terps are next.
Yep.
Pull this down. So I should be able to use this to give presentation power to somebody if you'd like it. If not, I can click through. So if someone can
hear me, I'm happy for you to click through. I'll just say next.
Great.
Okay, so next title slide, please.
All right.
Okay, so on behalf of our team, I would like to present CODI, your hidden immunity app. Next. COVID-19 has already claimed thousands of lives, but many millions more are stuck at home, out of a job, and worried about the future. New York City is the epicenter of the US epidemic, and this is also where we at CODI think we could start to make the biggest difference for ordinary people in the coming weeks. Next. CODI is a scalable solution for at-home antibody testing that makes a seamless connection between manufacturers and users. For individuals, it is an affordable, accurate, and easy way to get a COVID-19 immunity diagnosis without leaving their home. For society, CODI's anonymized data collection will help slow the spread of disease and responsibly speed up the lifting of quarantine measures. Next. Take the case of Mary. Mary had a mild fever 2 weeks ago and hasn't seen her elderly mother in a month because she's afraid it might be coronavirus. On Facebook, Mary sees that a friend has invited her to check out the CODI web app, where she sees a list of verified antibody tests that she can pre-order and where she too can invite friends to get them on this quickly growing wait list. Mary then fills out a short questionnaire on her symptoms, and as soon as the test is available, it is sent directly to Mary's home. Mary then watches a video demonstrating how to use the kit and uses a finger prick to apply a drop of blood to the test kit. 10 minutes later, Mary takes a photo of the results, and within seconds, CODI has combined her questionnaire answers and antibody test results to give her an accurate diagnosis. Mary did have coronavirus, but she is now immune and no longer infectious. Next slide. So CODI will initially be trained against images classified by experienced physicians, and we believe CODI will do a better job after roughly 1,000 images. But CODI does more than image recognition. It also combines questionnaire answers, historical location data, and antibody test output to give a better diagnosis than any one of these would be able to do alone. Next. The CODI team are exploring various startup grants to kickstart the process and are reaching out to manufacturers like Celex, Biomedomics, and distributors, including Amazon, to offer our upcoming list of pre-orders. We are aiming to increase public awareness of this testing option by getting users to recommend that their friends and family add themselves to this waitlist so that they can get the tests as soon as possible. We will improve customer satisfaction by ensuring that the tests are easy to perform and interpret at home, whilst also improving their accuracy. To cover our operating costs, we will charge no more than $10 per test through our platform, and we expect to reach 2 million Americans in the coming months. Next slide. So finally, we have a diverse team of microbiologists, immunologists, data scientists, app developers, and business professionals, and we look forward to taking your questions and moving forward with CODI. Thank you.
Great, thanks. And now questions from the judges?
Okay, this is Rowan. So what's unique about, you guys have anything unique about your lateral flow test, or is?
We're not providing the lateral flow test. There are already actually millions being sold, and we are verifying the producers with their sensitivity and specificity, and we are connecting them to the users as well as providing an app for improved usage of the test and image recognition, which improves the actual diagnosis.
Yeah. So you guys will be basically creating a list of.
Point out that this could be used by employers as well. Я им то предлагал, зайчик, они, it's always a lot of discussion about it.
I think someone might be off mute. So will you guys basically be providing a list of preferred tests that are, additionally verified?
There's a list of tests that have been verified, that are peer-reviewed studies. We provide them to individuals. They can sign up on this list. They are currently not available for individuals, but we would. Can we stop having interruptions? Thank you.
I'm trying to see who it is.
Thomas Ribeiro is not on mute.
Gotcha. Thanks for the answer.
Thank you.
So when you're talking with different manufacturers and you're exploring ways to produce this at scale, do you have plans to explore using this with employers and, with large healthcare systems who are determining if and when their healthcare workers are ready to return to work?
We have gone down that avenue and we've decided that actually the individual option would scale fastest. Healthcare centers already have a lot of these tests being delivered. it's fine, the FDA has approved that. We are getting ready a list of people for when individuals want at-home testing.
Great, thank you.
This is I do want to clarify that the FDA has decided not to regulate, at the time, regulate serology testing. Nothing's been approved. They just have waived kind of the.
All right. I have to stop it there. Thank you guys very much. Moving on to the UMD TERPs, if my knowledge serves. Oh boy. There we go. Okay, and next is Quaranteam. For the UMD TERPs, will I be clicking through, or would you like me to give somebody remote control?
Could you please click through?
Great. All right. Feel free to say next or next slide. Either one will work. And I'll start the time when you guys begin.
All right. So our group worked on identifying the immune. Next. In the disease model, there will be those who are infected who cease showing symptoms due to the antibodies developed, but they still carry the virus for some time and can infect others. Next. Identifying how long it takes for someone to no longer be contagious is a step in flattening the curve. Next.
So our solution is an app that will determine the timeline for users to return back to work. And we do that by assessing the symptoms experienced. Next. Our solution is unique because it has a machine learning aspect that allows for the development of our product over time, utilizing the data that users put into the system. It is a simple interface for all populations to use, example, the elderly, and it's not clinically intensive. It has it's part of a post-diagnosis plan that's not dependent on healthcare providers. Next. The population that we're targeting this app to are people diagnosed with COVID-19 via the COVID-19 test. And so we would be asking healthcare facilities to use this as a recommendation these plans for patients. Next.
Our implementation plan is split into 3 parts: data, questions, and app. First, we will collect data on symptoms, immunity timeline, and their association. Then questions will be designed to assess symptom severity. Finally, the app will provide a user interface to visualize the immunity timeline. Next slide, please. The methodology behind this app is being able to associate symptom severity with when immunity is developed. Questions on the app will assess this symptom severity. Then the number of weeks before immunity is developed can be calculated using this association. Next slide, please.
So as you can see, we have a quick demo of the app that you can play over there. It's a simple interface, so a wide audience can use it. And there are brief questions, so people won't have to fill out a plethora of questions and will be more motivated to use the app. As you can see, our symptom questions are tailored to the symptoms that are there, and we have a week output. Next slide. So what we did is we took each answer choice offered to the people using the app, and then we assigned points and weightages based off of clinical research that has currently been conducted by studies in Lancet and NIH. This is newer research, so it'll be adapted more as data is entered into the app using the machine learning aspect and allow us to refine the algorithm. Next slide.
So based on these point values and recently published research on the clinical presentation and assessment of the disease, we've created these recommendation cutoffs, which characterize the accumulation of symptoms as either mild, moderate, severe. And based upon that characterization, the amount of time needed to quarantine is calculated via an algorithm. Next slide, please. So this is our team. We're undergraduate students from the University of Maryland, and we have a wide range of interests such as epidemiology research, clinical research, coding knowledge, and this is all contributed to our collaboration efforts. We want to thank everyone for being able to participate in this competition this weekend. Next slide.
Great, thanks guys. Judges, letting you take it from here.
Hey, so how does this app differentiate it from calling your doctor and then letting you know how long to isolate and quarantine yourself for?
So if I could answer that, we wanted to decrease the load on the healthcare system. Currently, in some of the papers that we cited, based on the severity of the disease, there was an estimated amount of time before the immunity was reached. So the important thing to realize here is not having any more symptoms doesn't necessarily mean that you are immune and not able to pass the disease on to other people. With this time scale, we can determine the exact amount of time after the disease and the symptoms presented, and we can use that to determine how long the person should stay in quarantine.
For your reference, we've also included a flowchart of how we estimate our app will progress, and it's located on the slide after that. So you can click the link and it has an enlarged diagram.
Great, thank you.
Have you, hi, this is Ethan. Have you considered the opportunities for applying the same thinking to population level data that might be available in various health information exchanges?
Yes, so the data, it is going to be running through a machine learning algorithm, and we'll be able to build off of that. So we'll be able to feed in data and thus provide a better estimate for the users.
Wasn't quite what I was getting at. What I was thinking of is that there exist population level repositories of some of the data you're looking for, not all of them, of course, but it might be either a potential source or a potential destination of the data that you're working on, either the source of data or a destination for your recommendations.
Right, so what we could do is take that data and then incorporate it into the already determined cutoffs, and then, like Nikki mentioned, with our algorithm that could help make things more accurate. So that's definitely a step that we anticipate to take.
Okay, thank you.
Okay, thank you guys very much. Moving on to the next team. And really quick, I'm going to take a moment just to check the chat, make sure we're not having any technical issues. If we're having anything right now.
Henry.
Say it again.
I'm watching the chat for you.
Love it. All right. You let me know if anything's going wrong. Other than that, we're up on team Quaranteam. I get it. Yes. Quaranteam. And coming up, immunity first. Quaranteam, am I keeping control or giving somebody control?
You can control. Thank you. And we will say next.
All right.
So next, thank you. Hi, everyone. Unprecedented times call for unprecedented measures. More than ever, people and communities need to work together for our individual and collective well-being. Next. With COVID-19 suddenly infiltrating our lives over the past weeks, local officials and governments are implementing social distancing measures and large-scale lockdowns to restrict the movement of people. And it works. It allows us to safeguard our healthcare system, protect frontline workers, essential workers, and vulnerable population. And we assume that people who have been sick and recovered develop a certain level of immunity. However, social distancing is not a sustainable long-term solution, since it is a challenge for all of us social beings, and it comes with significant economic impact. Next. Kennedy. Kennedy, we cannot hear you.
Oh, okay, I'm sorry. The problem that we're trying to solve is how can we safely restore economic activity by predicting immunity? The Dow's dropped thousands of points, and 6.6 million Americans filed initial jobless claims last week, according to CNN. So it's very important that we allow people to return to work and reignite economic activity as soon as it is safe to do so. But the question is, how do we know when it's safe to do so? So we propose a free app. Next, please. A free app that local officials could use to determine this. The app would utilize several factors, including traffic flow patterns, confirmed coronavirus cases in the CDC database, and serological test results, and a predictive analytic model, which would provide an accurate estimate of the immune population within a specific region. Next slide, please. This information would be presented through a user-friendly graphical interface in the form of a map, where darker colors indicate a higher number of immunes, allowing local government officials to know when herd immunity has been achieved in their region and it is safe to resume economic activities in that specific region. Next.
So how to make the solution happen? Given the urgency, we want to take a pragmatic approach. We will need to develop a prototype and embed the solution into existing health applications that everybody has on their smartphones. There are almost 70% of the US population has a smartphone, and over 100 million use an iPhone, over 120 million use an Android. And it is absolutely necessary for us to work together across the public and private sector, and we would need partnerships with the CDC for the data repositories and potentially a public health awareness campaign, data robot and InterSystems for technical expertise, but also with companies such as Apple, Android, and telecommunications for implementation. Next, please.
I'm gonna have to jump in and cut you off there. Judges, we can start the Q&A and I can kind of flash through the remaining slides as we go.
Yeah, what is your evidence for making the assumption that zip code or even lower level data of incidents correlates or shown to lead to herd immunity?
I'm sorry, I couldn't hear that last part. Could you repeat?
So how do you know that herd immunity has been established based on zip code level population health data of incidents?
Well,
Sure.
obviously, as people test positive in a location, then normally they develop antibodies as a response. So it's more likely that they'll be immune if there are more positives in a region. We can also monitor serological tests that have been taken by users, and then especially as this is developed in conjunction with more at-home serological testing, that would also be one of the factors that's going into our predictive analytic model.
Gotcha. And accounting for travel in and out of, dense
Yes,
areas
to account for the spread. Yeah, so our idea was, we were talking with mentors about this yesterday, how we could use this app to potentially divide New York City, an epicenter of the disease, into different zones, and say if we saw that there was a cluster of immunity in the Upper West Side, perhaps we could open up the Upper West Side while slowly open up the Upper West Side to economic activity again, and then slowly phase in different zones throughout the city. So that's just one way that we could use that information to slowly reopen different locations. We're trying to detect herd immunity and make it clear to government officials where there is herd immunity, when we've reached herd immunity, so that they can make informed decisions.
Got it. Thank you.
Okay, we'll move on to the next team. Thank you guys very much.
Thank you.
Okay,
Thank you.
team immunity first, and next is team sharing is caring.
Hey, are you guys able to hear me?
Yep.
Would you mind giving access to present to Venkat Ramamurthy? I think he has his hand up. He's going to drive my slides.
All right, you should have control.
All right, we'll get right into it. All right, so thanks everyone. We are Immunity First, and we're here to present a symbiotic platform to prioritize the distribution of immunity tests. So we are a pretty global and a very diverse team. So currently there are an estimated 330,000 cases in the US, and our overall approach will initially focus on hotspots in the US, such as New York City. So everyone's kind of familiar with flattening the COVID-19 infection curve, but it's important to consider a much larger second curve comprised of people who want to be tested for immunity so that they can just return to their normal lives. So if the current shortages of the COVID-19 tests are any indication of what to expect, we anticipate a similar supply-demand imbalance with the COVID-19 immunity tests. What we don't want to have happen is what we recently saw in the news regarding the distribution of tests to NBA athletes, while essential frontline workers essentially struggle to obtain those tests. So right now, we're estimating about 200,000 people in the United States who likely have had COVID, but were not tested for it. And we are only at the beginning of that immunity test curve. So the first immunity test, manufactured by Celex, was FDA approved just a few days ago, but there's been no guidance provided by authorities or anybody else about how to prioritize receiving the test. So the specific problem we are addressing is deciding who should receive healthcare first. And providers actually do this every day with organ transplant selection processes. So every day they have to ask who gets the next healthy heart, for example. So our approach adapts the same process that providers use to make these difficult decisions. So we take into consideration key stakeholders that are necessary to get this done in an effective manner, namely patients, providers, payers, pharmaceutical companies, and even policymakers. And we've designed a socioeconomic platform that provides communities a tool to appropriately allocate immunity tests. For patients, this includes accurate information on where to get test times and wait times and stuff like that. For providers, it's a good platform for focusing their efficiency, who to test, and like effectiveness, and like where this should all be done. So our overall approach, which is based on risk prioritization, centers on improving two key outcomes. The first is rapid reduction in the incidence and spread of COVID-19, and the second is continued economic output from essential workers. So our HIPAA-compliant SaaS platform, Immunity First Exchange, allows the customers to seamlessly exchange data through APIs and drive personalized outcomes for each of their journeys and needs. So for example, for a policymaker, we provide a list of reasonable suggestive criteria that government officials can adapt and prioritize in high, medium, or low categories. And so why is this important? Well, it helps planning the immunity tests given to citizens in phases and allows high priority individuals to get certified and obtain an immunity passport first. For our patients, they can answer a few critical questions on an app, and that will be triaged, and they'll receive a priority score, estimated waiting time to get an immunity test, and even be able to schedule an appointment. So our final slide.
We're gonna have to stop there.
No problem.
Yep. Please, Venkat, would you mind returning? How do I get you off of presenting mode? But anyway, we can move into the judges portion.
So this is Susie. Can you tell us a little bit about your business model?
Sure. So the business model, I think we would be able to drive revenue through two. We have 5 kind of customers that we've laid out, but the 2 biggest ones we think, one would be pharmaceutical companies, those who want to be able to allocate their tests to the right population. The second one might be like the government, who might want to use this model as well to reallocate for our socioeconomic platform. So we've had I think we could drive revenue that way.
Hi, this is Ethan. What evidence do you have that the organ transplant allocation system is appropriate for here, that it's effective and acceptable and so on?
Well, I think it's just based on how long those have been used. So our platform, we want to be kind of clear that we do not necessarily, Immunity First does not necessarily assign weights to the criteria. We suggest criteria, but it'll be the decision makers, whether it's probably the government, deciding the prioritization of criteria that patients would kind of be able to respond to. So based on patient profile, they can decide how important that patient is to get the immunity test. So we're just kind of basing it off of other people deciding the importance of the criteria.
Do you have any evidence of how that was arrived at in the organ market that you think would suggest that this could be done sort of quickly and efficiently?
We certainly looked through it. I mean, we looked at, brain, heart, kidney, whatever organs. They all seem to have a very different, decision tree. So I think ours is going to have to be kind of unique as well to COVID-19, but we don't necessarily have, data to support their rationale. And so that's why we were like, well, we shouldn't try and support our rationale to decide who gets the immunity test. We'll leave that up to, Governor Cuomo, for example.
Okay, thank you.
Thank you.
Okay, thank you guys. Perfect.
Are we okay to drive the clicks, sorry, for you to drive the clicks?
Would you like to control presenting?
You go for it. You go for it.
Yeah.
I'm sorry. I heard 2 things. I heard yes and no.
Yes, you present, please.
I'll present. Okay.
Cool.
All right. Starting on your count.
Okay, then go to the first slide, please. So yeah, hello everybody, we're Team Tia, and we will now show you how we guide our users through testing and sharing of their COVID-19 immunity status as a contribution to society. Next slide, please. So all of us, we know that currently the media is overloaded with heaps of news on COVID-19. And in fact, many people are actually overwhelmed by the amount of confusing information on antibody tests and their trustworthiness. And this is because there's no clear guidance, a public one, and involvement on the why, what, and how behind testing. And most importantly, through the amount of negative media coverage, people now fear stigma and misuse of their data. Next slide, please. So we are now at a crossroad, as you can see. If we don't take any action, fear and stigma will persist. Or we can decide to take action, fighting the fear and stigmatization so that people actually do tests, share their results, and hence reduce the burden on healthcare systems and restart the economy. Next slide, please.
We've done a comprehensive gap analysis of solutions that are on the market and found that there's a gap in solutions that offer trust and also engagement via shared decision-making. This is where TIA comes in. Next, please. With TIA, we offer a human-centric approach to guide people through testing via an app and a public campaign. Content is tailored to you and your needs, and it comes from trusted sources. Next, please. We provide a seamless way for you to order and conduct the test at home. And for both positive and negative results, we guide you through what that means to you, and we provide you an easy way to consent and then share your results with the local authorities. Next, please.
Yes, and in fact, there's really strong evidence from healthcare councils that our solution can dramatically improve important key metrics. These are 50% reduction of healthcare service use, an increased adherence to governmental advice, and an improved emotional health. And this is actually the basis to overcome the crisis and then make people reintegrate into work and society. Next slide, please.
In terms of our business model, we will distribute our tests directly to consumers and go via employers, insurance companies, and local governments. We'll partner with diagnostic test companies to provide the tests and medical schools and organizations like the WHO for trusted content. Next, please.
So as a next step, we will now work on refining the idea and product and establish all necessary strategic partnerships. Once there's broad accessibility of easy and reliable immunity status checks, we will then launch our campaign and application, and we'll roll it out according to the geographic rollout of testing capabilities. Next slide, please. One of our success factors actually is the strong complementary skill set of our international team. So we have got a track record in many different areas, and with the next slide, please. With the support from our different mentors, we will successfully path our way to market. So next slide, please. Thank you, everybody, for having us in this MIT Hackathon Challenge.
Great. Thanks, guys. Judges?
Hi, do you have an example of something like this that's been successful in the past?
So, yeah, go ahead, please.
There are a number of examples of kind of applications that take people through shared decision making around kind of digital therapeutics. There are platforms, for instance, like Big Health, who help people with anxiety or take them through kind of a journey of overcoming insomnia, or companies like Omada Health, who through a guided experience help prevent people from developing diabetes who have pre-diabetes.
Thank you.
So sorry if I missed it, but I guess who's the customer paying for this service, or is there?
So we would sell this through employers. They would be able to buy out a kind of subscription or license and essentially offer this to their employees as a part of the benefit package. But also we'd go through insurance companies and local governments who would license this.
And this is Susie. Who again would be your strategic partners? Who would you pursue?
So go ahead, Joe.
So for example, now for the whole development around our application, so to make the content then also trustworthy for the patient, on the other hand, we would need then to engage with, for example, medicals and also psychologists that have got the proven knowledge, so to say, that make all our content trustworthy and that can then function for us as a sounding board, for example.
Thank you.
Okay, thank you, guys.
Pleasure.
All right, Team Immunoresponse. And next is Rice Medical Devices. Team Immunoresponse, am I presenting for you or giving control?
You are presenting for us. Can y'all hear me okay? Oh, yes, this is our orange slide. Okay.
All right, when you're ready.
Thank you. All right, welcome everybody. We are team #ImmuneResponse. If my microphone starts to go out, my colleague Elise will take over. All right. This presentation will propose a solution to the public health risk and economic recession due to COVID-19 through the development of a rapid, non-invasive test to assess individuals for immunity. Next. The economic impacts of COVID-19 have been unprecedented, including 6.6 million US residents filing for unemployment just last week, as shown in this graph compared to the Great Recession. By identifying the immune, these individuals can return to work safely, ultimately reducing unemployment and preventing many businesses from failing. Next, please. Next, please. To respond to the COVID-19 pandemic, we need to work the curves by addressing both the public health crisis and the economic crisis. This graph shows how the social distancing, the green top curve, exacerbates the economic recession, the bottom green curve. By identifying the immune, we can flatten both curves and help society return to work safely. Current COVID-19 immunity testing uses blood or plasma, increasing the bloodborne pathogen risk and patient discomfort. And need for trained healthcare workers. Next. We propose the adaptation to a non-invasive oral swab test in 2 waves, the first wave for immediate implementation and the second wave for product innovation. During wave 1, modified commercially available test kits will be used for the detection of anti-COVID-19 antibodies, IgM and IgG, in the oral mucosa instead of blood. This wave will focus on exposed essential workers and recovered COVID-19 patients. As a little background immunology, the presence of IgG indicates long-term immunity, while IgM indicates active infection. During wave 2, we will have developed and manufactured an upgraded test kit to include the mucosal antibody IgA to identify asymptomatic carriers. Next. Public health departments across the country currently utilize drive-through testing centers to identify high-risk patients and assign individual testing ID numbers. Adding on to this pre-existing infrastructure would make it simple to coordinate the immunity testing rollout across the US. Next. Once local immunity testing results are obtained, these data could be implemented into the current state immunization registries, allowing healthcare professionals and community members to look up their COVID-19 immunity status. As rollout continues, the system would be adapted to accommodate national data. Next. The #ImmuneResponse team will reach out to leaders in the diagnostic testing world and develop a prototype test kit for the detection of oral mucosa antibodies indicating immunity. We will further validate the prototype through implementation in the Texas Medical Center in Harris County, home to over 100,000 healthcare employees and 4 million residents respectively. Following local validation, we plan to scale this prototype up to meet national needs. The strength of our pitch lies in its innovative simplicity and utilization of current infrastructure and technology. Next. Oh, sorry, that's an extra slide. We have a final thank you slide. Okay, thank you, and we hope you join our team. We will now take questions.
All right, judges.
This is Susie. Just a quick comment. I like that you are focusing on joining into infrastructure that's already in place to address some of these challenges with implementation.
Thank you.
Great, thanks. And so you guys plan to develop the IgG, IgM, and eventually IgA tests in your lab or your team?
Yes, sir. So in the Texas Medical Center, we have lots of core facilities. An antibody core facility would be one. Also, partnering with existing companies would be another plan of ours.
The scale. That's I guess how do you guys plan to scale once you've proven your test works?
If you mean on the business side, that is actually one of our areas that we could benefit from, such as having a strategic partner, such as the someone with a business scale up. If you mean in terms of implementation, in terms of literally across the country, we would reach out to the public health departments across the states and the local governments.
We also have a number of connections to help us scale up this if we ever decided to move forward and take this national.
Great, thanks.
Thank you.
Thank you.
If y'all have any further questions, feel free to email us or find us somewhere. We're available.
Thank you.
Thank you.
Okay, thank you guys. All right. And next up, after I flip through these, perfect. The Rice Medical Devices Club. Okay, and then coming up is Escape the Room. Rice Medical Devices Club. Am I transitioning control or keeping it?
No, you can keep control.
All right. Go to your next slide. And whenever you're ready.
So hi, I'm with Rice Medical Devices, and we're going to be presenting a way to gather survey data to better predict immunity in both communities and individuals. All right, next slide. So our process starts with existing immunity tests. We're not creating a new one. Any test from Cellebrix or any other ones that currently exist. So the way it works is somebody enters a testing facility, a healthcare provider draws venous blood, and then they run the blood through a test. It usually takes about 25 minutes to get a result. And so the problem is, how do we pair this result with data? So next slide. So we're going to gather data through a survey taken with every test. So we're going to pair every test with a survey. And the patient fills this survey out while they're waiting on their test results. So this survey would consist of two kinds of questions. The first kind will be demographic questions, and the second kind will be more personal questions. So next slide. For the demographic questions, the information will be used to normalize the immunity data to the whole community in order to better estimate the total community immunity percentage. So the immunity percentage can be combined with another data point, such as total hospitalizations, for example, to create a plot. And so we can use this plot to sort of form a function of immunity based on another key metric like hospitalizations. And so you can see this relation for various cities. And we can use the relation to predict immunity percentages for other communities that have not had access to as many tests yet. So next slide. So the second kind of survey questions are for the personal information. And these questions will be like, how many people are you quarantining with? How many times has someone you're quarantining with left to go to a communal place like a supermarket? Or how many times have you taken a plane in the past couple months? And this data will be combined with the results from the immunity test to train a predictive model of an individual's immunity based on the answer to the survey questions. And so using this predictive model, a user could input the answers to the survey questions, and you could get an output of the probability of immunity. And so next slide. Actually, no, stay on the same slide, sorry. So what is the value in community and individual immunity estimates? Well, for the community, we can inform communities on how to predict how immune they are, so that when they do gain herd immunity, we can inform them of that so they can relax social distancing and quarantine orders. Because at some point, these social distancing and quarantine orders will have to be stopped. Similarly, we can use the personal survey data to predict who has the highest chance of being immune. And this can help if immunity tests are limited, but people want to know if they can go back to work or take care of their grandparents without spreading the virus and harming others. And so we could easily host both the public community data as well as the individual predictor survey on a simple website. So next slide. So in summary, all our plan requires is a simple addition of a survey to current immunity tests. With this survey, we can get data to make community and individual immunity estimates to inform communities and individuals about important decisions they will have to make, such as when to lift quarantine or who should get limited tests. And so we're now ready for questions.
All right, thank you. Judges?
Are you aware of anyone currently doing this on an individual hospital level or an individual health system level?
So we're not aware of anybody else bundling a survey with the.
And are you aware of any instances of other tests that are essentially bundled with a survey? You know, pick your favorite test and from a national provider or a large health system.
No, we haven't looked into any other tests having surveys.
Thank you.
What will the key questions or fact? Do you guys know what the key factors in your survey, what they'll be? And are there other ways of collecting that data besides just a survey? Is there potential use of the data sources to collect?
So there are certain community metrics that are already available, but those community metrics are for sort of the whole community. But the community that's going to be taking the immune tests are not a representative sample of that population. So in order to sort of normalize it to the rest of the population, you have to include demographic questions that you can normalize it to the rest of the population. And as far as individual questions go, there's not a huge database, you know, of like how many people have visited, how many other people, you know, whatever the individual questions that we're going to ask. We haven't figured out each one individually yet, but there isn't a big database on that right now.
Is there a key insight you're trying to look for in this survey that you can't find anywhere else that is going to be critical to actually, you know, finding herd immunity and other immunity trends?
Well, I don't think you can get a better estimate than having a survey of every single person that takes a test. No.
All right, thank you.
Okay, thank you guys. On to team Escape the Room, and coming up is BitBot. Escape the Room, am I keeping control or giving it to you?
Yes, you can keep control.
All right, you let me know when
Let's go. Thank you for the introduction, Henry, and thank you all so much for your time and attention. It's really a pleasure to have this opportunity. We're team Escape the Room, and next slide, please. And we're going to build a tool that connects local perspectives with global knowledge to empower decision makers at all levels in taking informed, data-driven action. Next slide, please. As members of the global scientific community, we know that solving the world's most challenging problems requires us to work together. But now, as we face COVID, a crisis on a scale we haven't seen before, we are failing to effectively collaborate. We have everyone from doctors to supply chain analysts working on this problem. But given the high degree of interconnectedness between the economy, public health, government, and the supply chains for critical products, effective decision-making requires a holistic understanding. Next slide, please. Although many communities face a similar core set of challenges, the manifestations of these problems, previous slide, please. The manifestations of these problems and their solutions are different across communities. One of the most inspiring themes of the COVID response in the United States has been the power and trust we have in the unique ability of local government and institutions to understand and address the needs of their communities. Next slide, please. Leaders need a tool that they can use to get a pulse check on their local situations, to evaluate different plans of action, and to examine results from similar contexts across the world. We need a tool to share solutions with the people who can act on them to drive change and to compare the effectiveness of different approaches. Next slide, please. Now, in the face of the COVID crisis, current collaborative efforts are failing to capture the massive scope of this problem. They fail to provide teams in vastly different domains with the adaptive framework that they need for effective international, interdisciplinary collaboration and decision-making. And they fail to have a tool that combines global and local perspectives. Next slide, please. We propose a global initiative that operates under a workflow that can successfully integrate work from experts across different domains and scales, and share it with the decision makers that can act on it to stop the spread of COVID-19 and restore our local economies. Skip a slide, please. Local leaders can implement their local approaches and then use this tool to compare with others across the world to see which approaches worked and in what ways and situations. It can help prime ministers decide whether they can afford to donate ventilators from their stockpiles. It can help regional health officials target balancing economic and health impacts of returning people to specific industries. Next slide, please. It can help principals assess the safety of reopening schools that many children depend on for meals. And it can give them real-time updates on successful disease control measures from other places. Next slide, please. Our team brings together a unique perspective and appreciation for the inherent complexity of the scales of this problem. We invite you to join us and support this project because we have a unique plan to foster global collaboration. Thank you for your time. We'll be happy to take any questions.
Okay, perfect timing. Thank you. Judges?
So this is Susie. Are you aware of some of the coalitions that are being created now, like X Prize, and I wonder if reaching out to them would be advantageous to show them this solution.
Absolutely, I think that's a fantastic point, and I think that one of the powerful approaches of this technique that's not currently offered by those is really bringing together leaders at different levels. So, like bringing together a mayor of a city and giving them the ability to look at what other cities are doing and what cities are maybe similar to theirs and what approaches have been successful for those. And I think other coalitions like that could absolutely inform this process. That would be very helpful.
Any other questions?
I don't have any questions right now.
Okay. Thank you guys. Thank you very much.
Thank you so much.
All right. Team BitBot. And coming up next when my screen loads, there we go, Blood Bank Network. Team BitBot, am I keeping control or transferring it?
Please keep control.
Sounds good. All right, when you guys are ready.
Yes. So BitBot is predicting COVID-19 immunity. Next slide. Am I immune or against COVID-19? That's the biggest question at the moment, and lack of data, testing capability limitations, and limited adoption of technology place some immense damage and waste resources in the health sector and the economy. And it risks lives of vulnerable members of our society. Next slide. The combination of data algorithms and health surveillance through BitBot gets better predictability before ultimately testing for antibodies. Italy, which has been hit hardest, is now looking into exactly that. Next slide, please. Immune healthcare workers ring fence infected patients and reduce the rate of infection. That's why it's so important to find healthcare workers who are immune. Next slide, please.
Our solution deploys the use of an app which is data-driven, it is predictive in nature, it has no impact on the healthcare system, and it is easy to use. Next slide. The tech stack we are using for the app is, the main framework will be Ionic, front-end Angular, back-end Node.js, machine learning tools, Skit, database management, Mongo. Next slide. So how does this actually work? We'll have periodic user status data, which the user will input. We'll collect also the passive data, which can be obtained from the user's mobile phone, such as a sleep tracking, a heart rate monitor, and these patterns. So we'll pass these patterns into our processing, which will consist of initially comparing with the data set that is already available with us, assigning different weights to the different parameters that we have collected, and then checking the relation. As we accumulate more and more data, our accuracy improves. Also, the data through oximeters and smart points, which can be available to some of the public, can increase the accuracy of the data. Next slide. How can just an app impact the situation? So it can help in breaking the pandemic spread chain. It can be made available to masses. It can be affordable by all, and it is not environmental hazardous as compared to a medical solution, which required a med kit and would require physical prototyping that would cause environmental issues. So it is easy to use. Almost everyone can use it, and it can send alert messages to the user as some apps are now deploying. It can assure a feeling of safeness among the people, which is required most at these times. It has special measures for less immune people too. Next slide.
So the total beachhead market, we believe, is 1.6%. We believe that healthcare workers in the US, 10% of them we are targeting. Next slide, please. The business
I got to cut you guys off there. We'll pass it over to the judges.
Hey, so how are you guys determining what key factors go into your COVID-19 risk score? And is that COVID-19 risk score associated with risk of exposure to COVID-19 or chance of immunity?
We have a lot of data which we collect, and the app is basically an aggregator. There's a lot of slides which show the impact. Aman, maybe you can add. Aman? Okay, so basically...
Please go ahead.
No, Aman, go ahead.
So we have collected, we have seen there are relations which relate to this data. Can you please advance to 5 slides? One slide more. One slide more. One slide more. One more. So here it is. Go back. So there are certain possibilities because the people have researched much less in the area of physical parameters being used as a test for immunity. We have so much scope in this area, and if we have enough data, we can predict more relation between these data.
And you guys feel as if you'll be able to create an index with enough confidence to actually inform behavior?
Yes, we believe that there's nobody looking into aggregating and really deep diving into the existing data which is available. Everybody has a silo solution. We see ourselves more as a platform with APIs attached.
All right, thank you guys very much. Next team, going blood bank network.
Can you hear me?
Yep, am I keeping control or giving it to you?
Keep control.
All right. Let me go to your next slide. Perfect, when you're ready.
Hi, I'm Dr. Inyang. I'm here with Mr. Keller, Mercer, and Abbas. I'm going to share our blood bank network solution. Next slide. Recovered patient blood is important in the development of vaccines and pharmaceuticals to combat COVID-19. Healthcare systems are currently overwhelmed, and we have limited capacity to reach out to recovered patients. Next slide. For example, Lily, a recovered COVID patient, found that the donation process to be very confusing, and she's still not quite sure how to contribute. Next slide. Ideally, research on creating a vaccine would start immediately. However, currently, gathering blood and plasma is not the main focus of hospitals. Researchers are also struggling to locate and obtain samples from the recovered. Next slide. That's where our solution comes in. We want to launch a centralized blood bank network with demographic info that's easily accessible to researchers around the world and does not burden the hospital and healthcare system. Next slide. Our first step is to contact COVID recovered individuals. We want to hit the ground running, so we want to start with our personal contacts in healthcare and tap into any available tracing efforts. Next, we will collect samples at partner locations, as well as collecting descriptive personal data with consent. Lastly, we will connect with researchers in biotech who will purchase the samples with the attached data. Next slide. Operations for us consist of building and housing a database with a user-friendly web-based interface for volunteers. We will also build and maintain relationships with hospitals and blood banks for keeping track of samples and storage. So we're mostly a digital platform that has very low overhead costs. Next slide. Our business model is very simple. As an organization, we'll provide a centralized network of COVID recovered samples with descriptive data. Our initial market is biomedical research institutions. Our value to them is accessibility and already mined personal data. The price point will be determined initially based on the market. For example, the price point today for 1 milliliter of HIV positive serum is $250. The existing ecosystem, next slide. The existing ecosystem regarding this matter is inefficient, so we're basically filling a void by being centralized, providing mined descriptive data, and empowering recovered COVIDs who are right now just sitting at home. Next slide. This is our team. We have lots of experience consisting of healthcare advising. I'm a physician and researcher. We have a biotech researcher and an experienced web developer. So we feel very confident that we can get this project up and running very soon. Next slide. In fact, we already have a website that's up and running for volunteers and researchers. It's covidblooddrive.com. Come check us out.
All right, thank you guys very much. Judges?
Hey, thanks. This is, I think this is a underserved problem that a lot of people don't realize. It's just sample collection and distribution. So thanks for tackling it. You guys, so you're basically going to be a two-sided digital marketplace for sample collection. It seems like, is that correct?
Yes, we are the network. So we're going to house the data and then make the connections between donors, hospitals, and the researchers.
Gotcha, but you won't be storing or shipping any of the actual samples?
No.
Okay, and do you guys have how many existing relationships do you have on the sample collection hospital blood bank side right now?
So I have my personal connections, and we all have research backgrounds, so we all have connections to universities, and I have corporate connections as well. I'm also in a network, multiple networks of doctors who are working on COVID-19, more from the clinical side. So there's stories every day of people reaching out, looking for solutions. So I'm pretty connected.
Gotcha. And so do you feel as if there's enough sample collection protocols in place at multiple hospitals? They just don't have places to send the samples, or are you guys going to help put some of those protocols in place at different hospitals as well?
If they need protocols, but the sample collection, that's done all the time with research. So we would obviously start with research institutions because they know how to store and sample everything. They know what the protocols are. If they need additional help, I could help. I have certificates in clinical research, so I could help. And I just finished a project dealing with blood banks, so I could help. But usually it's pretty standard how they store things. The AAB sets the standards. So
this is Zeno. We are looking to establish partnerships with companies and universities in New York City that are already doing this and establish best practices that can be distributed not only for collection but for the actual engagement with the patients throughout the whole process too.
All right. Thank you guys very much.
Thank you.
All right. Next we have Team Ubiquity Test, and coming up is Immunite. All right, Team Ubiquity Test. Am I keeping control or giving it to you?
Feel free to take control.
All right. Let me know when you're ready.
All right. So hello, everyone. And we are Ubiquitest. And we're a COVID-19 immunity testing consultation platform. Next slide, please. So next slide. So we know that identifying the immune in our population is the key to getting our society back on its feet. Next slide. However, we know that there's this crippling lack of testing, and we can see this happening across the world with New York being a main example. And we know that this testing, lack of testing is going to translate to immunity testing as well. Next. And we can even see in our places that have testing, there's a backlog of the test processing. Next slide. Next slide. So Ubiquitest is this digital platform that we're going to allow, next slide, the distributors, such as test providers and governments, to get informed decisions on, next slide, on how to effectively distribute and allocate the resources to their constituents based on location. Next slide. And so the Ubiquitest interface will allow somebody to enter an address, next slide, next slide. And then based off of demographic inputs, they'll get, next slide, an output on how they can save on testing and recommendations on how to perform their group sampling. Next slide. And so how is this test performed? We use a group testing methodology. Next slide. So imagine if there's 9 people, this is just an example scaled down, 9 people where one of them is immune and you're trying to find that needle in the haystack. You would first split the group into subgroups and then perform tests there. Next slide. And then next slide. And then the one that turns out positive, you would go in and do a second pass testing. Next slide. Next slide. And then you can identify that needle in the haystack. Next slide. So you would have 6 tests performed instead of testing 9 people. So you save 30% in this case. Next slide. So using an algorithm that we developed, next slide, we can actually analyze the effects of different parameters on the amount of tests that you can save. Next slide. We can see that we can have drastic savings in certain situations. However, there are certain cases where group testing isn't valuable and it can actually be detrimental. And so this platform is really useful for our users to allow them to identify what kind of benefits they can reap depending on their situation. Next slide, and next slide, next slide, next slide, next slide. Yeah, and so using this information, we can enable fewer tests, and with fewer tests comes less use of PPE that can be given to our healthcare workers to actually fight the infections that we know exist. And then this will also save time because we're performing less tests while still getting the same amount of information and allow them to ease back into the workforce faster. Next slide. And so we can compare with different testing approaches and where we maximize our accuracy for our resource efficiency. Next slide.
Got to cut you guys off there. I'll go through the slides, but I'm going to pass it over to the judges.
Sure.
I'll let other judges ask a question.
So tell us about your business model.
We would allow people to use this as a consultation platform. And so we would actually have users across scale. So not only you can go really high up with like the level of governments, but as well as users on the level of communities such as hospital systems, where the hospitals can distribute their resources to their satellite locations effectively based off of where they're located.
Okay, thanks.
Mm-hmm.
Is there, I guess, what's the precedent for, what do they do historically for group testing decisions and trying to determine herd immunity? Is there an existing kind of decision matrix that they use? How does this differentiate?
So the group testing was first introduced back in World War II for syphilis testing, where they would combine blood tests, and they did some economic analysis, but the difference there is that they did not take into account the benefits that you can reap based off of the fact that certain clusters will be more likely to be infected. Similarly, they started doing this in Nebraska, where they would take 5 swabs and test for the infected people, not the immune. And then recently, a study in Israel published on medRxiv was also talking about how they could use this, but up to 64 patients tested with one sample. However, what's unique about our system is that we're actually integrating this with predictive algorithms to see how certain households would be clustered together. They would have, if there's one infection in one location, there's a higher likelihood of there being more infections there. And so this is kind of the unique aspect of it.
Okay, thank you guys very much.
Quick sound check. Can anybody hear me?
Yep.
Okay, thank you.
Great. Moving on to Immunity, and coming up, the COVID busters. Am I keeping control or giving it to you? Oh, I think I have an answer.
Could you please give the control?
Yep, I think I just approved it.
Thank you. Hi, we're Team Immunity. This is a story of Dr. Michael, who is a senior pulmonologist. A typical day in his work would look like this. He's exhausted, he's not aware if he's at risk, there's not enough protective equipment, and he's worried for his health. So is his colleague, Peter. Every day we come across news about huge shortage of tests all around the globe. There's lack of protective equipment, and also there's this morbid fear of his colleagues dying. These numbers are really staggering. So our solution consists of 3 parts. There is a user-facing app and there is an admin app. We have devised an algorithm that will effectively determine the risk level of Dr. Michael based on the information that he inputs and certain parameters that involve FDA-approved antibody tests, infection history, and all of these parameters. The risk score will be calculated, and based on this, the admin will be able to effectively allocate protective equipment to high risk and critical sources first on a priority basis. Sajan?
Right. When Soumya finished, she mentioned that we are using end user perspective, and this is the UX for the end user perspective, where basically we are getting certain insights from the doctors themselves to basically give them a kind of a risk score that will be later used by personnel in the organization to kind of do something like a staff allocation that, for a high risk scenario. Or suppose there is a high risk scenario, you would be allotting someone with a lower risk so that you would be reducing chances of any kind of situations. Also, we try to look at edge cases where there is not a lot of available people with lower risk. So we go for a higher risk score personnel, but we look at how do we allocate the PPE resources as well. We also try to look at how the end user experience will look in terms of an app, where at this times of an institution, at this time, we want the doctors to be able to take a decision whether to go out to work as well. Also, the risk score of the doctors can be used to determine whether they need the PPE equipment on a priority basis as well. Soumya.
So our value proposition is being able to pair up low-risk people in a high-risk environment and thus reducing the illness and death rate among the healthcare workers, which is very crucial because they are the front line. They are working to help us. And as an added step, we can also partner with healthcare data aggregators like OneUp Health, who already have this data, and leverage existing infrastructure to build upon this. So now that Dr. Michael knows his risk score, he is not overwhelmed anymore, and Peter, who is at low risk, can take over his shift and help him out. That's it, and this is our team. We are a diverse bunch of people. We have on our team an oncologist with over 2 decades of experience, and we have 3 designers and a DSP engineer and a platform developer. Thank you.
Thank you very much. Okay, judges.
Are you aware of any institutions currently doing anything like this and assigning their healthcare staff? I mean, other than the obvious of the 70-year-old doctor who's been pulled out of retirement, probably shouldn't be in the most infectious ward.
Hey, Ethan, I'm not aware of, this is Dr. Matthew, I'm not aware of any risk-based assignment. I think that's really important. I think something analogous to that in the UK called shielding is being done in a tacit manner. But I think we need an explicit strategy to risk stratify personnel according to risk environments, which will translate into efficient and effective use of limited PPE resources, as well as reducing illness and death among frontline. First responders are a critical part of this equation, not just doctors and nurses alone.
Thank you.
Yeah, thank you for tackling this.
Are there certain, I guess, resource inputs as far as knowing the availability of PPE or other critical equipment within a hospital that need to be known to fully optimize this model?
It needs to have a flexibility associated with it. It's got two-facing, an employee health interface for input of information, and then on the business end, an administrator who knows his staff resources by their risk stratification and also knows availability of his PPE. That requires a hospital administrator to, decide on triage, because obviously in a battle-like environment that we're obviously in, they'll have to triage PPE based on availability and according to risk. So at least this interface will give them a strategic opportunity to have that kind of flexibility, which currently is a bit of a uniform assignment according to the risk environment, rather than taking the healthcare workers' susceptibility into it.
Okay, thank you guys very much. Please, let me take back control. Awesome. All right, some COVID busters, and next is Immunopass. And am I keeping control or giving it to one of you?
You're keeping control.
Great, all right.
Just checking, am I coming across clear? Can you all see me?
Yep.
Okay, in that case, I will begin. I'm Henry, and I'm excited to tell you about Snowflake, our integrated testing and predictive pipeline for COVID-19 immunity. Next slide, please. Say you're the director of the California Department of Public Health. You urgently need to determine which communities have the highest rates of immunity to COVID-19 and can be reopened. However, COVID-19 immunity testing solutions are ad hoc, with no guarantee that vital testing data gets back to your organization, whether a test is performed at home or in a clinic. Next slide, please. That's why we're developing a low-cost, in-home SARS-CoV-2 test to test individual immunity and to create a data pipeline and model to determine the likelihood of immunity within a community. Next slide, please. Key to our mission is a product pipeline that addresses the current disconnect between distributing tests to those most likely to have immunity and data collection and processing. Our target market is hospitals and other large health organizations who have an urgent need for integrated testing and data analytics so they can monitor the health of their communities.
We intend to print our microfluidic device from a digital 3D printer using PLA as our material. We will treat the PLA with PDMS and a cellulose suspension to facilitate blood wicking from the central reservoir to the peripheral nodes. After optimization, we'll use injection molding to make our product amenable to mass production and distribution. It will function much like a glucose test for diabetics in that the patient will use the lancet to prick the tip of their finger and apply a small drop of blood to the central reservoir.
The principle revolves around colorimetric assay, where immune antibodies from patient samples are recognized. The sensitivity and specificity of IgG and IgM antibody testing using microfluidics is compared to lateral flow. However, we aim to improve specificity by leveraging conservation homology of the spike S1 protein. Sensitivity would be improved by testing during the period recommended by us, ideally between 18 to 24 days after onset of preliminary symptoms. Next slide, please.
The other half of our product is an integrated data management and modeling service. We developed over the weekend a novel modification of k-means, which are, you can see our prototype on a screenshot of it. And we have this working prototype to identify clusters of people who likely have immunity so that we can go to them. Since we're working with large health organizations, we can leverage their privacy expertise to protect patient data that is collected through our service. Also, I just wanted to add that this model is not used for determining what quarantines are lifted, but merely for guiding testing to those who have the highest likelihood of having immunity. Next slide, please.
Our 5-step go-to-market strategy, developed under the guidance of a mentor from J&J Innovation, is to 1, partner with a clinical accelerator to establish clinical validation, 2, achieve FDA emergency usage authorization, 3 and 4 is to establish a partnership with a large diagnostics company such as Roche to gain access to their manufacturing and distribution network. These types of partnerships already exist, such as BD and biomedics. And 5 is to push out our product to the target market. We anticipate initially targeting the 18 million healthcare workforce. Next, please.
All right, I got to cut you guys off there. I'll flip through the slides while I pass it to the judges.
Can we stay on that slide for questions while we answer questions?
Hey, this is Rowan. So I found the model that you had to identify high-risk patients or likely immune patients interesting, and to target customer acquisition. Can you describe a bit more what the key factors that go into that model?
Yeah, I'd be happy to. So this model is a modification that we came up with. I'm a mathematician. I'm really interested in mathematical modeling. It modifies k-means. It essentially looks for people who got symptoms or had a positive immunity test. You can change the model depending like how much you want to weight these positive immunity tests. It looks for lots of people in a similar area who got a test around the same time. Specifically, say like one person got it and then people around them sort of in an area got it. And this predicts, oh, well, there are probably a lot of cases spreading in this area. This would be a good place to distribute immunity tests, since obviously every positive test is some resources saved if it would otherwise be given to someone who wouldn't test positive. I'd be happy to talk to you more about it afterwards too, if you're still interested in the math.
Thanks, appreciate it.
Have you modeled what kind of sensitivity and specificity you would need for your surface protein, viral surface protein testing? There's a risk there that if you don't want false negatives, and what concentration of virus can you detect, and so on. I'm not asking about the mechanics of the test. I'm asking about the parameters and whether your data model would, what specificity and sensitivity your data model would support, and your data analysis would support or would require, depending on how you want to look at it.
The IgG and IgM combined antibodies have a specificity of 97 to 100% using lateral flow, and with microfluidics, we expect similar specificity. To enhance the sensitivity of our assay, we're using both the S1 subunit, which has highly conserved regions and is specific for the SARS-CoV-2 virus. This has been tested in a paper that's been available in medRxiv. They looked at the antigen for the spike 1 subunit, and it had a higher sensitivity of 94%.
And
all right, thanks guys. I gotta cut it off there, I apologize. Okay. Team Immune Pass, and coming up, Team Avenger F Squad. Immune Pass, am I keeping control or giving it to you?
I'd like to have the control, please.
Okay. So you can request it, or I can share it with Sana. Do I have it right?
Yes, I will request it right away.
Okay, when you're ready.
All right. So we are Team Immune Pass, and we will help everyone to return to society safely. At a certain point, I need to know if my immune status, so I can return to work or to society. So let's meet Lucy. Lucy, in the coming months, will perform an immunity test. This is because her main wish is to return to her society, whether it's her family, to work, or to perform activities. But while she encounters those activities, and after she's taken the test, she is not sure how she can prove she is immune or not. So she remembers that at the testing, she got a QR code, and that's where Immune Pass will kick in. It will authenticate with the data from her electronic health records. And after a quick sign up to verify it's her, she will know if she's immune or not. So in our case, lucky for us, Lucy is immune. So with the Immune Pass, Lucy can safely return to society. But there are some extensibilities we like to address. So for example, Lucy can also store the vaccine data of her children in the app, but maybe also of her pets. And while she's traveling worldwide after the crisis, she can show that she's immune there as well. So for the coming time, we like to, in the beginning, we like to collaborate with electronic health system records such as Epic to run up a pilot. We'll get our prototype up and running, and over the time we will grow, and we have a wider release to address where the problem mostly occurs. By doing this, we create a continuous feedback and a loop cycle, so we can enhance the product and the service where it's needed the most. Coming with our backgrounds, we come from diverse backgrounds, but all together we have one common ground we stand on. We want to fight and tackle that when we return to society, we do not want to divide society, but bring it closer together. So, to summarize, Immune Pass is an extensible platform for immunity and vaccines, serving the whole family, and maybe even your dog. Thank you very much.
All right, thank you guys. Passing it over to the judges.
So schools currently face some of these issues of they look for immunization records. Hospitals look for actual results of immunization testing. So do you have antibodies against, say, hepatitis? Have you investigated that? And do you think that there's something to be learned from those more specific examples where institutions are already checking for immunity on people?
Yes, I think my teammate Haley can collaborate.
Hello, yes, this is part of the extensibility of Immune Pass, is that right now it's specifically designed to meet the needs of the pandemic. Right now it's specifically designed to reflect your immunity status to COVID-19, but the extensibility includes, in fact, part of our proposal is that it includes vaccine verification for your children so that they can go to daycare, they can go to schools. Even for your pets in the States, you know, we board our dogs and we have to prove that they have a recent and complete vaccine history. So we see that as all part of the extensibility of this platform. So we build the platform and then we add the functionality.
Thank you. I was curious also in the other direction, whether you've looked at any of the existing solutions that schools or healthcare institutions are using to track this as inspiration, as something to build on, as collaborators or competitors.
You know, there are histories available in electronic health records. To answer your question, I'm not aware of a digital solution which is widely adopted by, say, public schools. I believe that's still coming from the doctor's office in a written format, not a digital format. So maybe this is an opportunity also to expand in that way. In terms of major EMRs, Epic, Allscripts, Cerner, as well as some other key pieces used in doctor's offices. I mean, I think that there is digital opportunity, either through APIs or even a production of paper. You hand someone, it's got a QR code, they can just scan it in, and then the app actually sends that through another backend system to their school or their daycare or what have you. Much the way as we've deployed kind of smaller scale EMRs to physician offices, right? They're not on, these are independent physicians, they're not on EMRs and Cerners and They're not on Cerner, Epic, and Allscripts. They're on these kind of other solutions specifically designed for them. I can see that kind of a model working for, say, daycares or schools, right? They're not big entities in many cases. So I think we could hit it in both ways.
All right, thank you very much.
Thank you.
Okay, next Team Avenger F Squad. Yep, there we go. Okay, when you guys are ready.
Great. Hi, everyone. My name is Sarah Gerbach. What an amazing set of presentations so far. Thank you guys so much. I'm Sarah Gerbach here with Team Avenger from Kearney, and we're here to tell you a little bit about the essential topic of identifying the COVID-19 immune. So thank you for your time. Our solution focuses on identifying people who are the most likely to be immune to COVID-19, and not on the testing and development and deployment of these tests to our community, which we'd instead rely on our clinical partners to assist us with. Our plan has 5 major steps. Identify COVID-19 hotspots, reach out to the exposed population, screen potential candidates, facilitate tests and collect results, and build a database of this immune population. For more detail on this plan, I'll hand it over to Caitlin Hamrick.
Thanks, Sarah. Our plan has 3 components: target, screen, engage. To begin, we want to target highly impacted communities with high positive cases per square feet. We know that time is of the essence, so we want to be pragmatic in our approach. Second, we'll screen. Our product is a data-backed questionnaire to scientifically predict immunity. With testing resources being limited, we will use this questionnaire to help prioritize who should take the immunity test by determining their likelihood of being immune, as well as their likelihood of having a positive impact upon learning that they are immune. With each questionnaire taken and test result received, we will be able to improve the yield for predicting immunity to the level of accuracy where tests may no longer be required. Our platform will primarily be online, but we intend to have immune volunteers outside grocery stores and underprivileged areas to ensure those without access to internet have access to the questionnaire. Lastly, engage. We need to engage the communities to promote our user adoption. We plan to push text messages and social media ads to raise awareness of the platform, as well as partner with local governments and influencers to promote the message that immune people will have the ability for economic growth and community support through returning to employment or volunteering. I'll now hand over to Babak, who will walk us through our next steps.
Thank you, Caitlin. So as for next steps, I think there are 2 key critical milestones we're looking for here. We want to be pragmatic and aim to go live within 10 to 15 days with a questionnaire in the pilot community. And the second most critical milestone is we want to start sending tests and start collecting database in about 20 days. That's why we're trying to build this entire experience on already existingly available platforms, but also starting with a pilot that allows us to build on without overcomplicating the solution or the algorithms or any of the methods that we need to go. With that,
okay, I've got to jump in there and pass it over to the judges.
Hey, this is Rowan. What have you guys identified any key questions or parameters that you'll be looking for in your question?
Yeah, Rowan, good question. When we did the initial study, we identified 3 things as the key areas. One is exposure, whether or not you are in a high concentration sort of exposure area. Second is duration, in terms of whether or not the duration has been there. And then the third is whether or not you actually would have had symptoms, because the first 2 we talked about is for asymptomatic people. The second one is basically people who had symptoms but were never tested. So there are 2 types of people you're looking at.
Great, thank you. I guess follow-up question, do you guys plan to charge for this service? And if so, who pays for it?
No, not necessarily. So when we did the economic breakdown on this, the tests that are currently out there, the cost for them varies between $10 to $90. At the right yield and the right probability, the acquisition cost of an immune varies between 200 to 550 is the analysis with it. When you look at that and you look at the impact that person can have, whether from a socioeconomic sort of advantage they can bring back or from a healthcare system, the advantage is really offset by bringing these people back into the economy. And therefore our plan is not to put the cost burden on the people who are being tested, but much more so using local government funding for it.
Gotcha.
Okay, thank you guys very much.
Consider other non-government funds, like big companies and stuff.
Yeah, yeah.
Okay, over to ImmunoLink.
Hi, yeah, I'm gonna request access.
Yep.
Give me one second, I just want to make sure I am doing this correctly.
Yep, no worries.
Okay, great. Hi, we're ImmunoLink. This is Samantha. She was just placed on a 14-day quarantine after working in the COVID unit. Not only is she sick, but she's worried for her colleagues covering back-to-back shifts in her extended absence, and scared that when she returns, she still might be vulnerable to coronavirus. Samantha is one of likely thousands in this situation. Currently, 1 of every 3 doctors and nurses in one New York hospital are out sick, placing immense strain on an already overwhelmed health system. How can we help bring immune workers back to the front lines? So manufacturers are already ready to ship kits capable of rapid in-home immunity testing. But the FDA is concerned about counterfeit tests, and at-home testing increases user error. According to one VA health administrator he spoke to, verifying immunity status in a confidential, credible manner would be a gift to our critical healthcare work staff to get back to work safely. Introducing ImmunoLink. ImmunoLink can help connect buyer hospitals, test manufacturers, and frontline workers with a decentralized, privacy-focused, blockchain-based platform. In this situation, Samantha receives ImmunoLink partner test kit, scans the unique QR code using the in-app camera. We provide verification of the test kit authenticity, combine it with image recognition technology to accurately read results, and store the information securely in the decentralized blockchain. This allows for secure, easily verifiable, and most importantly, discrete confirmation of a worker's immunity status. Don't just take our word for it. We asked 20 physicians in our market research panel, and they said they'll feel empowered returning to work with independently verified immune testing. We are lab and EMR agnostic, easy to deploy, and thereby easily able to scale quickly and even outside of healthcare. This allows for a massive combined impact, especially considering that up to 50% of immune individuals were never symptomatic. It allows frontline workers to return up to 14 days faster, eliminating uncertain quarantine periods and saving up to 70% with the current market rates for replacement staff. It tracks immunity, allowing public health officials a macro real-time view of immunity status, and allowing to effectively deploy resources and identify immune donors. We have a diverse, multidisciplinary team from tech to physicians. We already have a working prototype, which we're about to share with you right now in the chat. But we need support and other key partners for the logistics as well as seed funding. So let's link up.
All right, thank you guys. Judges?
Sorry. Do you know what your potential both customers and patients are currently doing in this space?
So currently in this space, I believe that, I know that the VA has implemented temperature checks. Since immunity testing is very new to the market, especially in terms of COVID and the rapid screens, I don't know if there's any current protocols in place specifically for immunity testing, but I think right now I know various academic hospitals are only using temperature screening.
And do you have any historical examples, say from flu testing and, I mean, healthcare workers transmitting flu or acquiring flu is a similar, although less deadly version. Is there any background that you've found in that area?
Since there hasn't been, from my understanding, except for the 1918 flu epidemic, there hasn't been something of this scale that is this contagious. I haven't seen anything proposed for a situation with something with this level of transmissibility.
Thank you.
Just to clarify, you guys' value proposition is essentially verifying the provenance of the test, the immune test that is being administered either at home or in the hospital.
So correct. That's our main value. That's one of our value propositions. It also aggregates data to allow both hospitals and public health officials a macro view of the employees, both on a hospital level and a global, or I guess US scale. And this enables a lot of other technologies, such as identifying and allowing volunteering of immune individuals, or even connecting them with resources to volunteer in the communities if we were to scale it outside of the healthcare workspace.
All right, thank you guys very much.
Thank you.
And I think this brings us to our last, or one of our, we're close to last teams.
Great.
Maybe. I think we're getting there.
Can you hear me okay?
Yes.
All right, I'm going to request remote control now.
Yep. Okay, and when you're
okay, all right. Hi, everyone. My name is Kyle Fedorchak. I'm representing Waze Essentials, and we focus on the following problem. So grocery stores and pharmacies are currently overcrowded, leading to increased disease transmission. And as we brainstorm solutions to this problem, one of our team members, Jay, had a really real-world experience that I'm sure many of you can relate to. So just yesterday, Jay was looking to buy a thermometer and ended up going to not one, not two, but 3 different nearby pharmacies and still was not able to find what he was looking for. So really, this opened our eyes and showed us that the core of the problem is a communication issue, and specifically the communication on the availability of essential goods. In looking for existing solutions to this problem, we look to Waze, the transportation app, as a perfect analogy to what we were trying to do. And just as Waze uses user input to monitor car traffic as well as accident reports, we could do the same thing for foot traffic in stores and essential product availability for things like toilet paper and Lysol wipes. During our prototyping, we used Google Maps API to look at the popularity times for different nearby pharmacies. So we see heat maps here showing the relative popularity. And it's important to note that these popular times come from GPS data and refresh every few weeks. And taking this a step further, if we were to get that user-reported data like Waze has currently, we can generate similar heat maps for product availability, for instance, showing the relative number of thermometers at different nearby stores. Now going to a quick mock-up, here we have a map where the user would select their location of interest, and then they'd be able to provide feedback on their essential of choice after visiting that store. So for example, if the user noted that there is heavy foot traffic, they can click here, and that would complete the feedback loop and allow future users to make a more informed decision about where they want to shop and when. So in looking at the various pros and cons of our solution, we think Waze Essentials can help people to save significant time and also to reduce disease transmission for both store workers and individual shoppers. And really the golden path here is to get buy-in from either Waze or a similar store or company so that we can get this rolled out very quickly. In terms of limitations, there are definitely challenges with using user-reported data. For example, getting that broad adoption across a large user base. And again, that's exactly why we want to use either Waze or potentially Basket or another application to roll out our solution. And just in conclusion, we think Waze Essentials can help us to better navigate this challenging COVID-19 pandemic. Thank you.
All right, thank you. Judges.
So, I mean, one obvious integration is with the real-time stock management in these various stores you're talking about. How do you see that as a possibility and as a value proposition to those stores to bother to integrate with you?
Yeah, that's a great point. And one of the challenges that we thought about of approaching it that way is that stores might be hesitant to implement that because it might limit the number of people who would come to their particular store if they were limited on supplies. But of course, we did look at the marketing, the flip side of this, where we can potentially use this data and sell it back to these locations to tell them, hey, you're really limited on certain supplies in these various locations.
Another question is, are you aware of any efforts in this space to communicate availability of essentials in the current epidemic?
Yep, good question. So when we were looking into this, we found that the World Health Organization had some sort of similar concepts, but then when we looked at the specific app, really it only currently has kind of informative downloads and things like that. We couldn't find anything exactly like this. The BASC app looks at kind of price comparisons across different places and potentially can be updated to integrate this information as well.
Thank you.
Thank you.
Okay, thank you guys very much.
Thank you.
And team immune status tracker. And coming up is last team pitch, which I think is probably aptly named for our last team's pitch.
No, this is the last team. So sorry, that was poorly worded.
All right. There we go.
Yes, sir. Yeah, can I have a remote control, please?
I think you should.
Okay. Thank you. Thank you so much. Last but not the latest, this is immune status tracker. And basically, you have seen isolation. We are in isolation, right? We have to, and we are in the social distancing perspective. So how can we come out? So that is something like in working inside the lab, we face a lot of like problems having the production batch records not moving to the production line. So the formulations are stuck and such things. So all this derived into the problem description, which is in the next slide. Okay. So what we are looking for is a personal device, which is a home device, which can be which can have a reusable solution at any time, and it is expandable because like we can have the data set changed because it's a driving force and can be changed, and this can be useful for maintaining the immune history. So what happens is, if at all we want to track the status, that is helpful. And what outcome it gives is the peace of mind, right? We can go out and with confidence and with courage, and we can like go out. So now, how does it work, right? So we developed this using a software Python, and the analysis front end will be connected to the mobile. It's a blueprint only model right now. So the outcome is basically through the blood injection or the blood test, and so basically the data is transmitted through the Raspberry Pi 0, which is a low cost interface which connects to the mobile and gives the output. So this is traced and tracked. So what is our implementation pipeline, right? Right now in the hackathon, we completed the scoping, design, and the conceptualizing phase. So the next 4 weeks, we can get to the development build using the model, because I recently heard that in 2 days before that, the FDA has approved the Celex and Mayo for its blood test. So for its antibodies, which means this can be used once on we can use this immediately, and next 1 week for the mobile app, and that is a durability testing, and this encompasses a DevOps strategy, which means we can have a continuous feedback loop, and we can interact with the hospitals and get feedback with the practitioners and everything, and showcase our things.
All right, thank you very much. Got to cut you guys off there.
Yeah. Thank you.
To the judges.
what advantage do you guys see to your, I guess, app-connected test versus some of the lateral flow tests that are being developed?
So the benefit of this is, see, anyone can buy it from, can use the Raspberry Pi and buy it. They can use it at home. They can see if it is, if I'm prone to, I'm immune or not. So that will give them, okay, I can go out and I can mingle with others. It will track the IgM and IgG by targeting the specific antigens.
Got it, but that's the same thing that lateral flow tests that don't require Raspberry Pis, technologies, or a phone buys and provide an offline readout for the same information. Is there anything that the app connection or the digital tools are adding additional value to for this?
Yes, yes. So the reason why Raspberry Pi is chosen is because we can scale up at any point in time. Say the data set changes, right? Now we have COVID. Later on, it might be something else, and SARS went and left us. So the changing dynamics of it can be tracked very easily using the Raspberry Pi. That is the reason we had a middle layer, a hardware layer as a Raspberry Pi, which can be programmatically changed and ingested with the data sets.
Got it.
Yeah.
Okay, thank you guys very much.
Thank you.
Awesome. So I just want to say thanks everyone again. It looks like we still have about 100 people on the channel. So thanks everyone. We're pushing, of course, I think our final presentation was supposed to start at 4. We're pushing that, obviously. And we're going to work with the judges right now to come up with the prize winners. So I will make sure all the information you guys need is in your track channel. And that way we can join the final presentations when they happen. So thanks again for all your guys' cooperation and patience. We've been working really hard, and even though it's been a learning curve for everyone, I think some great things have come out of this, and I've been really excited to see you guys work on what you're working on and be so passionate about finding these solutions. So thanks everyone, and we'll see you at the final at the prize presentation seminar, I think is what we're calling it. So see you everyone.